No. What I'm talking about here applies to just about everybody. In fact, it's more than 80%. I think it applies to more than 90% of the patients. Now, of course, the cohort that I see in my office are patients who already have coronary artery disease or they already have had a heart attack. So those patients are kind of easy for me to convince that, hey, listen, you already had a heart attack now. You want another one? Well, you already have had 2 stents, and then you're going to get the third one. So you need to do this, and I'm going to put you on this program. Okay, that's fine. But then there's another cohort of patients who come to me, and I do a coronary calcium score, and it's high. But they're asymptomatic, and they've passed their stress test. So let me just tell everybody who doesn't know about coronary calcium score, because this is so important. And I'll tell you why it's important. So it's a CT scan, low-level radiation of the heart, and it looks at the amount of calcium buildup in your coronary arteries. So it tells you already have atherosclerosis. So there's no guessing that, oh yeah, your cholesterol, your blood pressure, your weight, and therefore your risk of having a heart attack in the next 10 years is such and such. It's going to plug you into a formula. No, this is, do you have the disease? Yes or no? Do the scan. Yes, you have disease. Do the stress test. Pass my stress test. Why? Why did I pass my stress test when I have calcium in my arteries? Well, you passed the stress test because your blockage in your artery caused by the calcium is less than 70%. Because it takes a blockage more than 70% to reduce the blood flow in it. And then you may have symptoms, or you may fail your stress test.
Can we just back it up a second for people? Like, what is ischemic heart disease? What is atherosclerosis? What is a stress test? Because I think there'll be some people listening who probably may not be familiar with those terms. And I think it would be quite useful to sort of set that foundation, if you don't mind.
Yeah, they're very important. So atherosclerosis is the buildup of plaque in the walls of the arteries, and they occur everywhere, in your neck, in your brain, in your legs, but most importantly in your heart. So when the walls of the arteries develop calcium in them, it's atherosclerosis. You cannot get atherosclerosis without calcium. Actually, you can, but very little. Most of the time, there's a lot of calcium with it. So the calcium is a surrogate for the plaque buildup in the walls of the arteries. And that calcium buildup, the atherosclerosis, can cause 2 problems. It can narrow your artery down on the inside, so the pipe becomes narrowed, and therefore that causes ischemic heart disease. Ischemic heart disease, lack of circulation, lack of blood flow going down that artery, therefore the muscle is deprived of blood, and the patient may experience pressure, tightness, heaviness in the chest, particularly on exertion. That's called angina. So angina, chest pain, is because of lack of circulation due to the plaque, which is picked up by the calcium and a positive stress test. Now, a positive stress test is where you exercise or we use chemicals to simulate an exercise, and it can tell us the consequences of the blockage. Is my blockage more than 70% or less than 70%? If it is more than 70, it may reduce the blood flow in the muscle, and you'll pick that up on the stress test. The stress test can be a nuclear stress test or an EKG stress test. But now, if your blockage is more than 70, you are more likely to experience chest pain and the effects of the lack of circulation in the heart muscle. And depending on the location of that blockage and how much muscle is getting the effects of the lack of circulation, your cardiologist may opt to either put you on medicines, or if you're having very bad symptoms, maybe you don't put a stent inside, which we can talk about. But what I really want to stress here is that you can have a blockage, atherosclerotic, calcium-laden blockage that is less than 70%. You pass your stress test. You have no chest pain. And those are the patients that I'm seeing in my office now, because they're coming in, they're getting the coronary calcium score, which they would not have otherwise. Because you go to your primary care physician's office and they say, oh yeah, your stress test is good, your cholesterol's fine, your blood pressure's okay, yeah, keep going. And the guy gets a heart attack within a year or 2 years. And so what happened to me? Well, because you already had the plaque, you just didn't know it. So the coronary CT scan that we do, low level, looking for the calcium, picks up the calcium in the walls of the arteries and quantitates it on a score that goes from like 0 to 4,000. Over 100 is significant. Between 100 and 400 is very significant, but over 400 is critical. That means you really have a lot of calcium in the walls of the arteries. So these are the patients who coming in, they do the scan, and I see that they have all this calcium in the walls of it. Now I turn around to them and say, did you know that you already have atherosclerosis? You already got it. And we have studies that show that coronary calcium is going to predict whether you're going to have a heart attack or a coronary event or a stroke or even total mortality more accurately than all the other blood tests put together. So now I say, now, do I have your attention? You already have. See, you got to motivate the patient. And this is my carrot. And I'm like, look, you have atherosclerosis. Now I want you to do my program. Now I'm going to look for some parameters on your blood test. I'm going to see what's causing this calcium buildup. And the patient says, but I'm fine. I said, yeah, but you didn't just build this up. Something is making your coronary calcium build up. So let's find out what it is. So I do a Kraft test, I do a full physical examination, I'll do tests, advanced lipid panel. These are tests that I do in the office to see, and then I might even inquire into the gastrointestinal health. I'll do a whole evaluation to see why this patient's building up this atherosclerosis. And part of the treatment program is going to be my fasting program, which I think is the #1 program for this. So those patients are very happily motivated because I show them the coronary calcium score. I said, look at your picture. This is it. Check it out. You got this calcium. Another group of patients, they come in, the 80% that you're referring to have metabolic syndrome. So for the sake of the audience, I'm just going to tell everyone what metabolic syndrome is.
Thank you.
This is a derangement of your metabolism. And basically it means that you're overweight, your body mass index is greater than 25, and you have an increased abdominal girth. All the weight is around the belly. And there's actually a ratio that you can do between the waist and the belly. The belly is increased. And then the HDL, the cholesterol, is low. The triglycerides are high. And they have borderline high blood pressure. Now, when you look at all these numbers, what's the common thing that comes to mind from everything I've already said? Is insulin. It's all about it. Insulin lowers your HDL, increases your triglycerides, increases your abdominal girth because all the fat is down there. Remember what insulin does? Insulin puts all your calories, excess calories and frequent calories, and because of the high insulin levels, puts it where? Into the liver, pancreas, and visceral gut. And that fat is totally different from the fat that you put on all over your body when you overeat. When I overeat, just eating a lot of fats and, okay, that's different. But the fats that are produced under the influence of insulin by the liver, de novo lipogenesis, the new fats that are created, the glucose has to be converted into storage product. The storage product is that fat. That fat in the liver gets deposited in the liver, pancreas, visceral gut, is very inflammatory. Composition is totally different. You do a biopsy of it, you'll find inflammatory cells in it that are producing tons and tons of interleukin-6 and tumor necrosis, bad stuff. So metabolic syndrome, although you have these basic features, when you do additional biochemistry on them, you will find that they have increased CRP level, which is a blood test for inflammation. And if you can do even further testing, you will find that they have very high interleukin-6 or tumor necrosis factors, and they have small, dense LDL particles indicative of inflammation. So these patients come into the office for prevention, or they're sent to me because they have a low HDL. And these are the patients that also I'll do the fasting program. So some patients are motivated to go into my fasting program and lose the weight that way. Because you see, the weight, by the way, I gotta tell everybody, the weight is a side effect of the metabolism that's gone wrong.
Yeah.
You fix the metabolism, the weight comes down as a side effect.
Yeah.
It's not really a weight loss program. It's a metabolic program in which one of the side effects is that your weight comes back down to the way it's supposed to be. Comes back to the way it was supposed to be. So, so these patients come in and they get referred to me. So I almost invariably do a coronary calcium score on them. But even if the coronary calcium score is not very high, the metabolic derangements are going to make coronary calcium in the future, and I motivate these patients to start making the lifestyle changes by showing them that their metabolism's off. Now, these metabolic tests are not being offered by every doctor's office and nobody, because it takes a lot of effort, and the insurance companies sometimes don't want to pay for it, like the advanced lipid panel. Sometimes they pay for it, sometimes they don't. So what I did in my office is I developed a program where it's a cash paying. If the insurance doesn't pay for it, okay, this is how much it's going to cost you, but get the test done. It's a good investment, and I have to show them that that it's going to change their life. So, but you're absolutely right that this metabolic derangement is not 80%. It's probably more than that. And it's very, because I'm seeing it in children. I mean, just the other day I saw a mother bring in her 16-year-old, and I'm like, and I said, I'm not a pediatric cardiologist, but there you go. She had all the derangements already at the age of 16.
This is so